Thank you so much for all the great presentation. Perhaps I can start with a comment and maybe a question to Dr. Kapoor. I think your last message was probably the most important one, that the relapse will happen no matter what we do, no matter what selection, salt, or other scoring you use, there would be relapse. But what do we do after transplant to avoid that relapse goes from a sleep to a dangerous drinking and resulting in loss of the graft? And even the Accelerate study, the follow-up that they have published a couple of years ago with 5-year follow-up, they have a number of early and significant relapse to alcohol, with some of them losing graft at 5 years. And I think that what you say in terms of the hepatologists, we don't know much about AUD, and the addiction specialist afraid of liver disease is an important point. So don't you think that we should bring those two together and have a system in place where this patient not only go through transplant with the help of addictions specialists and psychiatrists that allow us to understand the severity of AUD and the underlying psychiatric disorder that needs to be treated, I think personally pre-transplant, but also provide them support post-transplant in order to avoid this to become a bigger problem. And I think that would only happen if we have an integrated program that brings these specialties together.
So absolutely, I couldn't agree with you more. So I think you've summarized the whole talk very nicely. The paradigm in this country is a little different because you don't have insurance for transplant. So the patient and the family has to pay from their pocket. And oftentimes it's a very dramatic kind of a presentation, especially the early liver transplants. And the moment these patients walk out of the hospital, the care that is provided even by the caregiver also dwindles over a period of time. So what I did not mention in the talk is that most studies have shown that the median time at which the relapse occurs is about 11 months. That is pretty much also the time when we as physicians have become overly confident of the graft being good and functional, and the number of visits to the clinic starts to go down. So earlier on, especially for high acuity patients, we would probably see them 2 times in a week or at least on a weekly basis. But as time passes, their number of visits to the clinic goes down. Similarly, because the whole family and the immediate caregivers have been so much fraught with the problem of sickness, they also tend to relax a bit. And oftentimes, I completely agree that there should be an integrated approach, but even if you ask them to see the clinical psychologist, and in my practice, I have stopped using the word psychiatrist because it carries a huge stigma. So we always say that no, these people are only going to talk to you, they are not going to drug you, and we all need to know that CBT and MET is much better than pharmacotherapy. So even in spite of our best efforts, it's very difficult to make them see a clinical psychologist. So those are the potential problems. But we all know that you can rapidly have graft injury. It can happen over a matter of months, as well as graft failure. But these are the problems which we find very difficult to grapple with, because these patients are very smart. In our country, drug default also happens almost simultaneously as soon as they start to drink in an hazardous way. And it's only when they look at choleluria that they suddenly realize that something terrible is going to happen, and that's when the family members also start to get reinterested in the patient's health status. So that's the situation in our country.
Dhamesh, very nice talk. Can I just, in the context of India, where dominance is live donor liver transplantation, do you think the relapse rates are different because these are the caregivers are same as the ones who have donated them the liver, like the daughter, son, or wife? And then that equation actually changes in terms of what is going to be their social behavior after transplantation? Do you think that actually impacts the...
I wish you were true. I've been hoping all these years that was true, but
so
that isn't.
I wish in the sense that we have published on this actually, that the relapse rate in live donor liver transplantation are actually lesser than the DDLT. The figures we see from DDLT from the West and the one we publish are actually quite different. We had a relapse rate of about 6% or so, and that too heavy drinking was a rare thing to happen. And graft loss because of heavy drinking was again a rare thing to happen. So I think there is an impact, because when you see this patient in clinic and when the donors are accompanying them, and these are the same people who have donated the part of their liver, so I think they feel that pressure on them to behave properly after the transplantation, and I think that makes an impact.
Yeah.
Dr. Sibal, I have a question for you. Sorry, yes, just 1 second, very quick question. Congratulations, I think that's fantastic that what you are doing with the children transplantation in India and going from 0% survival to now almost 90, that's great. The fund that you are able to raise, is it only for your own institution, or does it apply for all the Indian transplant centers?
Thank you very much. Well, you know, in India, health is a state subject, so every state has their own way of delivering care. That's the first point. Second, we have the private versus the public healthcare systems, where there is funding available in the public health system, but there are only a handful of hospitals that have actually embarked on a pediatric liver transplant program on the public side. When it comes to private, each institution has got their own way of trying to raise funds, because when it comes to pediatrics, you will need to rely on funds. Otherwise, you're not going to be able to do more than 5 or 10 a year. Because the reality is biliary atresia is a disease of the poor. I can count on my fingertips in the 28 years that I've been practicing here, affluent families that have a kid with biliary atresia. I don't know why, but it's a reality.
So, Dr.
Yeah.
Sibal, yeah, please.
This question regarding MELD scoring system, I think there is one pitfall in this. In MELD scoring system, if a person goes on warfarin and the INR iatrogenically increase, the UNOS does not do any correction. They give them liver. And this was not addressed. I think we must address this thing.
In the first slide, I put the MELD evaluation. MELD without INR, that also I mentioned in that. It was in 2006 paper, it has been come out. With those who are on anticoagulopathy. So that time, without INR, the MELD score.
But that's absolute now. The recent one which are we using for ENOS in America and Canada, we do use INR. And if person goes on warfarin for some other reason other than this, they go up on the list automatically in the computer generated list, and they get the liver. I think that needs to be addressed.
Dr. Joy, so you spoke of MELD. Now, in our country, we don't have a national organ allocation policy, or most of the transplants are living donors still, at least in the northern part. So where do you see MELD? So we basically use these scores to decide when a patient needs a transplant, and rather than, for organ allocation. So I personally think, I don't think beyond MELD, I think it's before MELD. I still like the child score actually for deciding when a patient needs a transplant. So what's your thought on that?
So the MELD score is always better than the child score actually. But we are, in India we are using all the sarcopenia frailty not for the indication for liver transplant, even though the patient is medically fit based on the MELD score. But if the sarco very severe, the sarcopenic, that liver frailty index is more, that parameter we are taking, the patient is not unfit for transplant. So to say the patient is unfit, for that we are using the other parameters. But of course, the portal hypertension related, all the complication, whatever they mention, that time we are all not looking into the MELD score. For example, recurrent hepatic encephalopathy, refractory ascites, recurrent hydrothorax, recurrent SBP. These all, so the transplant centers, we are not looking into that. That's a MELD exception.
So I think, Neeraj, I completely agree with you, because the MELD score has been designed and oftentimes we use it as the Western world use. So that's because you have to share from a common pool. In the north of this country, we are doing predominantly living donor liver transplants. The commonest indication for transplant in India is still diuretic refractory ascites. These patients are typically low MELDers, and because of our phenotypes, we tend to become sarcopenic pretty soon. And if one were to go with the MELD, score, then it might become too late and too difficult. So because you are because we are relying on living donor liver transplant, I completely agree with you that MELD does not mean much to a living donor liver transplant scenario.
Yeah, you're absolutely right. We often have patients who have a CTP score of 10 and a MELD score of 10.
So just like somebody mentioned about warfarin, so MELD manipulation is extremely easy. So again, that is a problem. You start giving diuretics to someone, you will have a drop in sodium, you will have an elevation of creatinine. So these are the potential pitfalls. But in a living donor scenario, that really does not make much difference. Professor Kamath, would you like to say something about the MELD and anything, that for this audience, anything that you would want to?
There are the two issues here. One is as a gauge of severity of liver disease, and the second is for transplant allocation. So the advantage over CTP is it's got a much wider range. But if you're not using a cadaver system, then it doesn't matter. So you use whatever you're comfortable with. And often I say it's the eyeball test. You know this patient requires a liver transplant, and use whatever you wanted. And to follow up on Joy's thing, the reason for the 40 cap was just someone decided 40. There was no reason for that, because they said if it's too high, then there's futility, and they thought above 40 will be futility. And we know that was a mistake. So someone decided that. So the original model was still infinity. So you can go to a very high score, and that was just very artificial.
Dr. Dharmesh, a lot of transplants for alcohol-related liver disease are now, ACLF patients or severe alcoholic hepatitis patients. So do you do you transplant all of them? Because obviously you can't follow any score in them. And how do you decide? Do you have a psychosocial way of saying no to any of these patients, or you transplant all of them if they, are fit for transplant?
Yeah, so fortunately, we are not doing those many living donor transplants, so that's, I would say, a saving grace for us. But to come back to your question, like I said, these are the patients who rapidly have a cognitive decline also on many occasions. So you really cannot gain an insight into how the patient's mind is working. So pretty much it depends on the psychosocial support, whether he has a stable job, whether he has a stable partner. You can use the family history of an addiction disorder. So these are all the trajectories that have been studied in earlier studies. But none of them is infallible. You can always go wrong in your assessment. So even like Dr. Pameja said, that if a daughter or son is donating, we have seen those patients faltering too. So I don't think there is a foolproof method of preventing this problem.
So Dr. Sibbal, I'm going to ask you something. Basically, you did say money doesn't matter in pediatric transplant. I think money is the biggest problem in terms of pediatric transplant for Indian kids actually. And I haven't seen a patient, we do fair bit of pediatric transplant, and I have yet not done a pediatric transplant who has not been funded by an external agency or or if they've got an EWS card. So on pocket money spending on transplantation by parents in pediatric transplantation in India is actually a rare thing to happen. I haven't come across that. And that's the biggest challenge actually you face, because a lot of patient comes up but they don't have money and all. The second problem of this equation is the timing of transplantation, because we see a lot of Kasais being done beyond 100 days, and then the patients are being pulled up and they spend more money before actually coming to the transplant. So I think that's a more important critical issue in terms of deciding and actually coming down to cost of the transplantation, because this all get counted in their pocket. So what's your comment on that?
Thanks for Dr. Pamecha. Perhaps I didn't make it very clear. Money is the biggest problem, but it is no longer a problem in our program because we have so much money. Because we figured it out. It's not crowdfunding, it doesn't work, it doesn't sustain. You have to have people with very large hearts, deep pockets, who are willing to commit unlimited amount of money, only then it works. But you're absolutely right, it adds up. First the Kasai, then the cholangitis that invariably develops, then the 3 hospital admissions, then the malnutrition. By the time they come to us, they're in dire straits. So finances is the key. We just have to be innovative in terms of finding solutions.
Thank you for all the speakers and my co-chairs.